Unbeknownst to me, I was very lucky to have followed Janet because some of her discussion on fibromyalgia had to do with gait speed, and we'll address that as a function of mortality in a few minutes. This talk is an offshoot of a long-term study that we're doing with older adults who use water just to walk, and they were in therapy for a myriad of reasons and continue in a water walking class. And they actually asked, can you measure some things for us? And it kind of took me to look at, oh yes, I know gait speed, I know stride length, I know step length, but what else should we be looking at? For the majority of our folks were involved with us because of orthopedic issues, and so I started with the orthopedic piece. In the beginning of this, I'm sure some of the repetition as far as land gait might be redundant for what you know, but we're trying to use that as reference points when we talk about the water. So when we talk about walking, really it's a function just to walk. And they were in therapy for a myriad of reasons and continue in a water walking class. And they actually asked, can you measure some things for us? And it kind of took me to look at, oh yes, I know gait speed, I know stride length, I know step length. But what else should we be looking at? For the majority of our folks were involved with us because of orthopedic issues, and so I started with the orthopedic piece. In the beginning of this, I'm sure some of the repetition as far as land gait might be redundant for what you know, but we're trying to use that as reference points when we talk about the water. So when we talk about walking, really it's a function of our independence. And at both ends of the age spectrum, it's a big deal. As a toddler, all waking energy is spent with getting upright and moving somewhere, maybe not forward. As we progress, we can walk as a multitask and independent function. I can walk and talk. I can walk and talk and carry things. I can walk and talk, turn corners, and avoid obstacles. At the end of the age spectrum, however, it also becomes a challenge. And walking and talking may be too much. It might need to be that every bit of concentration is on that function of walking. So it really does epitomize our independence and our functional piece. The other part of walking, and what we need to really consider as far as both physical therapy and this little talk, is the fact that walking, because it integrates so many systems, the musculoskeletal, the respiratory, the cardiovascular, the input of the whole neurosystem based on what we do as far as mechanoreceptors, might be indicative of underlying pathology. And that's kind of what we're trying to look at today. So it should be synchronous. It may not be, and to that end, we really need to be very diligent. On your handout, folks, I want to go just real quick. Stride length and step length have been transposed on your handout. So a basic stride length is about 28 inches. And the stride length is defined as 2 successive heel strikes. If I start with my right and then my left, it's that. Step length is 2 successive heel strikes of the same foot. And these parameters, while we think, oh my gosh, I want to do the math, me neither. We want to look at normal values. The big one, though, that we really want to focus on is the walking speed. And it's calculated to be about 1.37 meters per second, which translates to about 3 miles an hour. That's what research tells us. Now, at this day and age, we also need to really consider what an age factor. At 70, at 80, the oldest person in the walking study that we're doing is 96. I hope they make it to the end of our study. And I don't mean that. I don't mean that in a disparaging way at all, because I have a story at the very end that kind of still knocks my socks off. When we talk about gait speed, it's the best measurement of functional criteria. Something else we want to think about, though, is gait speed is really indicative of survival in older adults. And there's a study in JAMA, 2011, had a subject group of 34,000 older adults. And what they did, a little over 34,000. Anyway, what they did is they tried to match life parameters, heart rate, blood pressure, O2 sats, BMI, all of that, and tried to correlate that with something that we do functionally. And what they found is there's a very high correlation between decreased gait speed and mortality. And they actually have a graph. While I'm not going to actually spend a lot of time on the specifics of that, suffice it to say that when we find that someone has drastically altered their gait speed, meaning less, it may really be indicative of an underlying pathology that might not be described in the standards that we normally use, heart rate, blood pressure, etc. What this study intimated as far as for physicians, you do all of this work and blood work and yada, 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 and you don't really do anything to say functionally is the person okay. So kind of like all their standards are in place, but they're dying. And that's what John is trying to do, is actually promote, can you do a 10-meter gait speed in your office, or 10 foot, or whatever, and get some parameters. And we'll talk at the very, very end of this. So it might be really a very subtle message of disturbances in multiple organ systems. So when we talk about gait sequence, we all know stance phase and swing phase, 60-40. A couple things to think about, though, when we're talking about our older adult population. An increase in that double limb support time, that percentage gets closer to 30, and we have not only significant gait deviations, but probably a balance issue as well. The other thing is when that swing phase and stance phase become 50-50 or 40-60, swing to stance on one side, we also want to look at some underlying pathology, the possibility. Let's talk a little bit about structures, and starting out with the pelvis. First of all, if my pelvis is not moving well, I have a drastically increased energy expenditure just to walk. So at mid-stance, which is if I'm starting on my right and it's heel strike, at mid-stance, my pelvis should be somewhat anteriorly tilted, talking 2 to 4 degrees. Conversely, I push off posteriorly. If I don't have that, that motion has to be taken from somewhere else. It might be my hip. It might be my low back. When we talk about low back and walking later for water, the piece is that we might find, hey, that person that gets in the pool, walks, they're unloaded, they're great, and the next day they say, you know what, you killed me. And I'm dying here. I can't even walk in my home. This may be a piece of that. Also, in the frontal plane, we want to think of what we're doing with our center of mass. We think about it on a higher level in balance. But center of mass, if I'm walking and my pelvis needs to move, it doesn't. It's an increased energy expenditure because other muscles have to compensate to try and get other structures moving. Also, if I have a drastically increased pelvic movement, increased energy expenditure. You know, the Marilyn Monroe gait maybe might have been fashionable in her day, but it really wasn't too helpful with energy expenditure or with good structures. Talking about requirements for our hip, we need that 10 degrees of extension. We find in the older adult, even in normal gait, and some of these studies are very small subject, so I'm just bringing this up, throwing it out there, that if we don't have 10 degrees of gait extension, hip extension and gait, we have real aberrant movement and the possibility of not only increased pain, but also decreased balance. Frontal plane, in stance, I am abducted. In swing, I'm adducted. And if you think about that, if I'm standing here and swinging this leg forward, that's accounting for that pelvic motion. We'll talk strength on that in just a second. The hip is moving our pelvis forward on a fixed femur in stance, and that's a big deal. And that accounts for, if we're doing that with 3 miles an hour speed, great. If we're doing that at 1.75 miles an hour, we're working really, really hard, increased energy expenditure. Knee, we also need 60 degrees of flexion, and we need full extension, or we're working too hard. At the ankle, at least 10 degrees of dorsiflexion on land. We're going to talk way different story in the water, and about 20 degrees of plantar flexion. We also have, it's really triplanar in the frontal sagittal plane. We need those motions on land. We really don't need any of them in the water. We can start stance in a flat foot, and we can finish stance in a flat foot in the water and be stable, safe, and moving well. The shoulders and trunk. About a 7, and depending on whose research you read, 7 to 8, there's even some research that says 9 degrees of trunk rotation. If we don't have that, we disrupt the movement of the center of mass. We also drastically increased energy expenditure. So when we look at why someone is slowing down, is it, you know what, this is just too much work. Maybe I don't know how to move. Maybe I have orthopedic issues that preclude me from moving correctly. But oftentimes, looking at it as the mortality piece, we can also look at that a little differently, that if they're not walking, we are maybe setting them up for being very deconditioned and creating that issue of a metabolic situation. Land gait. In walking on land, it's about 20% max muscle contraction to walk, and to walk efficiently. Talking increased speed, we've got drastically increased muscle contraction, drastically increased energy expenditure, but normal gait speed. And the adductors are really the most, those are the guys that are on the most. Here's the deal with them. They, and this is a recent study out of Marquette University, Dr. Donald Newman and his group of biomechanical researchers, realizing that the adductors are on to assist the hip flexors. The adductors are on to assist the hip extensors as well. And so they are working really as a stability primary muscle movement and also constantly as assisting. And so when we talk about gait and we look at your strength for the hip flexors and the hip extensors and the knee flexors, etc., we oftentimes fail to really incorporate adductor strength. Hip flexors. Concentric and eccentric is the big piece that we're trying to get out of this, and not so much who's firing when, but realizing that in the water we're probably not training anything eccentrically as far as gait. Hip extensors. We need that concentric contraction the first 30 degrees of gait to prevent the jackknifing. And again, going back to energy expenditure, our older adult, the increased mortality, if we do not have good hip extensor contraction here, my pelvis moves forward, hopefully, but hopefully my back extensors are strong enough to stop this jackknifing. Jackknifing, moving forward, even ever so slightly, puts us at a really increased risk to fall. Again, we're talking orthopedics today, and balance and gait in the water is a story for another day, but drastically impacts our balance if we're constantly jackknife, or even getting into a 10 to 15 degree trunk flexion each step. Abductors, terminal swing, they're very important. They do a lot with eccentric control. And then the adductors, really they contract to stabilize the hip, and they assist with extension predominantly. They also assist with hip flexion in that swing and placement. Not so much work on swing. Internal rotators, important with the fixed femur because they really help to stabilize the pelvis hip component, and external rotators can help with that advancement of the pelvis and hip. Interesting in a lot of the research, internal, external rotators, abductors are nailed. Adductors are not mentioned. So just an interesting piece. Knee extensors, very important at late stage of swing, and their major activity, though, occurs after the initial ground contact. And what the knee extensors are doing is trying to promote the continuity between this femur going forward and not taking my body weight with it when I'm not stable. That's a big deal. And oftentimes what we find is when I don't have good stability with that tibia moving forward, I'm trying to either decrease my stride length, which is going to decrease my speed, or I'm actually going to walk more stiff-legged. The stiff-leggedness might not be just because of pain. Flexors active at late swing, and then they eccentrically slow down that knee, the knee extension. Dorsiflexors and plantar flexors. Dorsiflexors, really their major activity is after initial heel contact. And really what they are doing on the other end We just talked about the knee extensors, but on the down end, the distal end, they are also trying to control that tibia and put that plantar flexed position so that we're going over this very loose structure, and it can ultimately become a rigid lever for us to catapult over. Plantar flexors control the tibia and prevent that uncontrollable knee flexion from the distal end. The trunk. Big deal here because there is slight activity both before contact, and it also controls the movement of the trunk. It really helps to effectively control our center of mass. If you think about walking, just basic walking, picking them up and putting them down, it really is a continuous process of finding your balance and losing balance. We're stepping, our base of support and our center of mass are aligned, and then we step out of that base of support. So it's very symmetrical. It should be very synchronous. And if our muscle firing is off, we already are set up for not only falling, but a very slowed gait. And then the rectus, very slow activation throughout the gait cycle, does have a burst of activity with the hip flexors, and it just to stabilize the spine and pelvis. So we talked about land, got land out of the way, and really looking at the water. And the reason that we started this way, first of all, I'm a simple mind, and I'm not a fast learner, so I had to go with what I like. And looking at when we are talking about how does water walking help you? We know a lot of things about water walking and exercise and how we can increase gait speed, etc. But just water walking. And the reason for this is because many of our folks, we're all in the same boat as far as treatment. We're getting less visits, more copay per visit. Folks are coming less, saying, I can only come once a week. So the responsibility for me is to try and give them something that they can effectively do correctly at home. And we have a lot of open pool time, but also something that they feel, hey, I'm making some progress here. And to that end, that's why we're discussing what we are today, to ask them to really think in terms of joint angles, etc. might be a hard sell. But when we can show that they can walk a little faster, a good thing, and maybe turn a corner without worrying about, am I going to lose my balance? So that's kind of where this is going. We want to talk about the considerations of water walking, certainly the biomechanics, the differences, and there are some significant differences, obviously, and then the use of it with just two very simple diagnoses. And I'm fortunate to have the experts sitting right up in front on that. Water walking. We know a couple things about it. First of all, the depth alters the ground reaction forces. The deeper I am, the less I weigh, okay? And because of that, there's a drastic alteration in joint compressive forces. The piece of that we need to realize, however, is that there is literature now saying that if I don't have those compression forces and the normal mechanoreceptor response for weight bearing that I know on land, and that might be partially hardwired, perhaps that's why I'm not walking correctly in the water, or that's why I'm not able to activate the same in the water, or the delayed reaction in the water. So that's a component that we need to think about. Just like any exercise, one exercise does not work for everything. It is very beneficial for some things, but there isn't one exercise that absolutely works for everything. So we want to look at that too. Anterior, posterior ground reaction forces, me getting through this thick medium, we don't have on land. Obviously, we have that in the water, and we have some research to show that at specific joints. Increased drag adjustment are adjustments in the cyclic phase of gait, and we'll see those per joint in a minute. Drag force also drastically alters our posture. So if in fact we're talking about we're trying to make you more upright, it certainly is, number one, depth dependent, and number two, cueing dependent. If I have someone at waist depth and I say go faster, I'm going to certainly benefit by flexing my trunk forward. If I have someone at chest deep and say take longer steps, I'm I'm effectively throwing them back. So we really need to be careful in our cueing. That's not to say you can't have them take longer steps. It might be also that we need to speak in terms of, okay, let's take one step at a time to train that to start out. So again, the specificity of training is alive and well with gait in the water. The internal net joint forces and the torque we need to consider. They're drastically decreased, and that may be part of that mechanoreceptor response. We also have to be careful in that we say, you know what, you have no force working against you in the water. We do have some forces that are very specific to joints and also may affect the actual pain component in those joints. We're going to talk about the biomechanical differences and certainly less muscle activation. And I think the group from Utah State did some work on muscle activation of the trunk and found that decrease in the water. So again, if we're talking about using gait and gait sequencing to improve trunk strength, we might need to be careful. Also, there's an increased need in the water for concentric contraction. We talked about that. But really, when we're planning a session, either a treatment session, a bout of treatment, or planning that post-treatment program, we need to really think on what we're going to say as far as speed and how much that weight is going to be reduced. We need to take some ownership in the fact that our instructions need to be very accurate, but also the fact that if I can walk in the water and I can move faster in the water, I may not care about my trunk being here. So it's our instruction specific that is our go-to. A couple things just in comparing the water. This is a first study, and this was done by Orselli et al. Interesting study because these are young people. Very small subject size, obviously. But what they had them do is walk comfortably at self-selected speeds. And they set up a video, and they had a force plate. On land, just walking, and at chest depth in the water. So it was for just a two-dimensional gait analysis, and here's what they found. A couple things as far as stride length in the water, a little bit decreased. Stride period, stance phase, significantly increased. Stride velocity in the water. If you take a look at that, that's about, maybe a third of what land is. So if we're training gait speed and saying that, we need to be careful if we're just walking. We're going to qualify that at the end. But vertical ground reaction forces, you can see how much it's reduced, water versus land. And anterior-posterior ground reaction forces, negative 0.04. I don't know how that could be negative, but that's their research. But actually, they did an equation basing body weight and their depth on the speed. But when you look at the water, there's 11.9. That's force, AP force. They're having to work against that to move. So when we talk about walking in the water, and I'm saying, hey, you might not be so accurate on the speed, realize also that working against that force, all other things being pretty equal, we may in fact really be able to improve gait speed. And we'll talk about that in the end. Okay, this same study with Orselli, talking about specific torque at very specific joints in comparison land to water. Range of motion, pretty close, not a big deal. But when we talk about the flexor torque of the ankle, land and water, significantly increased in the water. And that goes all the way across, except for the knee, decreased at the knee. And that may be a function of a couple things. That may be a function of a continually flexed knee. The study was not very clear in that their biomechanics were perfect. They set a self-selected walking speed. But fairly interesting, too, about the extensor situation in the water. When you talk about, especially the knee, decreased extensor effort in the water, and obviously the ankle, the hip. So some real discrepancies when we look at just the minimum biomechanics there. So what does this have to do with our water treatment I'm having someone just walk. And folks, please realize that we're not talking about any water exercise other than walking. This is what we're finding. When you add exercise to it, a whole different component. Hopefully good, by the way. But water walking, we find that really we have a decreased internal joint force, which we knew. Increased hip joint force, though, is needed really to propel the body forward. We may get that if we have a real self-selected speed that they stay at. We may diminish that by decreasing the speed. If I'm not going as fast, I don't need to propel myself forward with as much effort. In the young population, which this is, not such a big deal. In our older adults, it might be significant enough that they're now going 10 minutes of water walking versus 20 minutes. What are you trying to accomplish with the water walking? That's the million-dollar question. Really doesn't offer a great deal of decreased musculoskeletal loads compared to land, and as far as locomotion in the AP situation, and drastically increased. So we have to be careful of what we say there. And folks, if we're trying to unload someone in the water and we say we've got you at chest deep, you're bearing a third of your body weight, that's standing still. When I start to move, those forces change, the same as they do on land. If I'm standing still, I weigh and have this much force going downward and ground reaction force coming up. As soon as I start moving, that force changes. If I start moving faster, that force increases. Obviously, if I start running 6 to 10 times my body weight with each, 6 to 8 times my body weight with each strike. So this is what we're talking about as well. When we're thinking of unloading, again, what do you want to do with the water? And just to be aware that, hey, I can load that person up pretty intensely. I was at a talk this weekend, and the gentleman was talking about trying to get someone with a hip labral tear, a young football player, a D2 school. And he said, the doc had done a repair and said he could bear 20 pounds of body weight. That was it. So he put him in his tank and said, look, I've got him up to the shoulder. But the guy weighs about 250. So 20 pounds, 2 times 250 is way more than what the doc wants him to bear once he starts walking. And again, that's the point I'm trying to make. And then the similar kinematics are noted land to water, but certainly decreased angular speeds and altered muscle firing. What are we trying to train? If I'm just trying to get you in and get you picking them up and putting them down, it might be great. If I'm trying to train eccentric deceleration, might not be the place. Not to say I can't get you in there, but I need to really focus on the specifics of that on land. Second study. It's Barella et al. And Dr. Barella had done a study early on with young people. This is an older adult population. And what she did is she did the exact same study, just repeated the first study that she had conducted, not the study that we quoted here, and then just compared the data. Exactly the same format, just with 50 years difference. And had 10 subjects, walked at self-selected speeds, land and water, did chest deep, and in both of her studies, she had them walk with their arms up, so arms out of the water. It distorts your weight component, also distorts the forces a little bit, but had it the same way. Stride period, as far as the elderly land, and then look at water, significantly different as it was with the young adult. The length of the stride in the water, significantly different. And the speed, of course. And again, the point I'm trying to make is if we're trying to train gait speed, we may need to do something else also. Initial contact. This is the ankle, hip, and knee. And just interesting in the elderly individual, significantly increased angle as far as the knee in the water. And that may be a function of, that's at initial contact. That knee may have been drastically flexed because it's easier for me to bring this shorter lever arm from the swing phase. And so as I'm putting it down, I've actually got drastically increased knee flexion. what are the implications for our treatment? First of all, slower speeds, shorter strides. Secondly, we want to think in terms of increased ankle plantar flexion noted during the stance phase. And if you think about that, many of our folks walking in the water are on tiptoes. I can start my stride on tiptoes and I can finish it on tiptoes with no disruption in my balance in the water. How many are working in pools of 78 to 80 degrees and folks don't want to get wet? So certainly that is a component that we need to, it's not that we can't use the water, it's that we need to just be aware of, and again, specificity of training. Increased knee flexion noted both at initial and end of stance phase. That's something we definitely don't want to promote anywhere because that's the issue with some of our older adults. And again, hip joint flexion noted throughout, but not hip extension. Comparing the older and younger adult, the slower speeds, increased knee flexion, and decreased dorsiflexion. So those are just two studies as far as strictly looking at balance, speed in the water. And now, here's what we've got as far as stride length, stride frequency, and speed. In the water, we know that we can activate that gastrocs, no problem, but it's just delayed. But the tibialis, which is an important component for those that are having decreased dorsiflexion at swing phase, to get that foot up, and then certainly when we put the foot down, that's important. Tensor fascia, working harder. Tensor fascia lata. Biceps femoris, in this research, certainly much more activated and important. Trunk, I can definitely activate increased trunk just by using my arms. I can, in the water, if I'm using my arms, I can get increased trunk rotation. And so hip comparison, pretty much equal, but we probably can use our extensors a little more in the water if we train for that and the specificity there. The function of the hip is different on land than in the water as well. Knee, decreased flexion, pretty much occurrent during the first 15% of stance, but we accept that and we have that flexion taken through stance. Ankle support, decreased support required in the ankle, and my ankle behavior can be very aberrant, and I still can propel myself forward. So, looking at just the summary, decreased speed, stride length, reduced vertical forces, EMG pattern is way different, and that's something that if we're training muscle specificity, we need to get them on land as well. So, how do I do this water walking? Backwards can facilitate hip and knee extension. Lateral walking, I might actually be able to maintain my center of mass in a better position. Remember, if I've got a hip away, I might be hip hiking off that, trying to move this leg forward off the painful segment. And then we can certainly, marching accentuates that hip and knee flexion. But folks, something to think about too is familiarity with the water. If I am someone who has done a lot of water exercise, I understand the strategies of the water and how it moves. And regardless of whether you're a good athlete or whatever and never have done anything in the water, those first few times can be tough. So speed I can work on. There are multiple studies that actually say we can improve speed in the water for land by working in the water. But all of them that I found incorporated some other exercise. We can really improve hip extension as well. Trunk rotation, we can actually work on that and working on pulling the body through using our arms. So if we can train trunk rotation in the water, we need to now just adjust our treatment on land. And then with knee away, all of these that we've talked about, we see, let's take it to, so what can we do with the knee away patient in the water? We know that less pain, and Janet really addressed that well previously. We can actually increase the activation of the quadriceps, which might be something that we certainly need. Multiple studies demonstrated increased speed on land post-aquatic intervention, but all of them had an exercise component, so it wasn't just water walking. Toe walking can improve the calf strength, We may not want to promote that for too long. And hip OA, decreased walking speeds and distance, shorter inconsistent step lengths, decreased weight bearing on that affected side. And so what can water do with them? We decrease the joint forces, so I may be more apt to walk because I'm not as painful. Increase in consistent step lengths, we can do that in the water, and improve that paraspinal strength. So last thoughts on water walking, though. We might want to stay away from saying that just if I get you in the water, you're definitely going to walk faster on land. We want to be careful. The water doesn't facilitate, unless we plan it, normal land-appropriate step lengths, and encouraging land-appropriate knee flexion, not necessarily, and the dynamic balance component. As far as my end story, we're doing this long-term study, and I have a patient who was my patient for quite a while, had bilateral hip replacements, has been walking in the water. He's 80 years old. He was 80 years old. His heart rate, his last recorded resting heart rate was 65 beats per minute. His last recorded blood pressure was 119 over 60. His O2 sat in exercise was 98 to 96. His initial gait speed was 2.8 miles per hour in land, which is hideously fast for somebody 80 years old. We do a land test every 8 weeks because I have people drop in and drop out and yada yada. His last gait speed that we did was 1.7 miles per hour. So big difference. 2 weeks later, he had a massive heart attack and died. And I bring this up because I was a little concerned about just taking speed and saying, okay, well, you're pretty slow, you're probably sick, which is what the doc was alluding to. I would not know these results except for the individual having expired, and I'm just the worker bee taking the measurements. I don't know who was doing what and who we're doing exactly what with. It's a doctor initiated study. But suffice it to say, I have bought into this gait speed thing. I'm jumped all in now. And I believe, too, that what we need to think in terms of is looking at age-related gait speeds, but also looking at all of these other components we talked about as a piece of that gait speed. Obviously, his was on the mark until it wasn't. So, folks, thank you so much for being here. The folks that have done a lot of research on walking in the water and arthritis are Dr. Dalney and Dr. Bressel. So they're probably better to answer any questions than I am on that. Thank you once again, and have a great rest of the conference. If you have